access to primary care, and that in 2008 we funded a clinic in Akron to have one-stop shopping so that people come to the mental health center, they can get the health care as well as the mental health care that they needed. And since our inception in 2001, we've made about 580 grants to various mental health kinds of activities, and granting about $3 million a year. We were really trying to focus our money so that it could leverage change and leverage transformation. And one of the ways that we looked at doing that was, how could we help people have better access to services? How could these services be more recovery-oriented rather than waiting until they get real sick? And one of the programs that we initiated for people, especially with psychotic illness, was a FIRST program, so that early on in the illness, before the folks got on disability, before they had to leave college, they could get intensive services to help them with their psychotic symptoms upstream. And this upstream idea of helping people with mental illness is one that I think we have been trying to innovate on as much as possible, looking for ways to connect people with their transportation, their work, the ability to stay active in their communities, not to become isolated. Programs that, for instance, in Ashland County, we supported a small grant that the consumers in a small storefront consumer-supported program to buy 6 sewing machines. And with these sewing machines, they created quilts, each square representing an area of their recovery. And through the support that they gave to one another, they started to build on this. And working together, they learned more about better dental care. They learned more about better health care. And one of the things that we've noticed as a foundation is that because we grant make in 18 counties in Northeast Ohio, is that various kinds of the mental health system is county-based, and we have regional hospital systems, and so we thought we would work together with some of the hospital systems on regional outreach. So we supported a telepsychiatry program, and so in Akron at SUMA, we're doing telepsychiatry appointments with a mental health center in Dover, and we're having some success with that. So what we're basically trying to do is innovate around the areas of things that we know that work, but also working out the difficulties in those relationships, those funding streams, and those things. And we're doing some bi-directional integration by putting mental health staff into healthcare clinics, and we're also doing the other, which is taking healthcare folks and putting them into behavioral health clinics. And we're finding that those relationships are now developing, the quality of those relationships and that interaction and that interdisciplinary ability is really what makes the difference.
Thank you. Let me, since the microphone's down then, let me start with Thom. You know, as a longtime funder of innovative projects in treatment and support for individuals with severe mental illness, when you look at the data for Ohio, and particularly for the Medicaid program, this continues to be an area of opportunity for improving care for individuals with mental illness. Where do you see the critical gaps in the current system that we have, and what have you found to be most effective in improving health?
Well, I think that for us, the gaps are that people with severe mental illness are very isolated, and there is a lot of stigma around going and getting help. I mean, people are hesitant to go get medical care. Then when you talk about going and getting mental health care, wouldn't it be great if we could go to a primary care physician, and that primary care physician would have a strong relationship, if not even either a telehealth or an actual presence of a behavioral health person in their office, so that the stigma is eliminated, that you can go to a pediatric office and get full service care, that those two systems aren't separate. And we're seeing some progress in this area. One of the areas that we funded in Wayne Holmes County was, interestingly enough, a project to help healthcare professionals become more aware of suicide and recognizing signs and symptoms of suicide in their offices. And many of these offices are Cleveland Clinic offices. And there was great success in the mental health board staff working with Cleveland Clinic offices to the extent that little Wayne Holmes Worcester came up to Cleveland and did a class, and now we're looking at leveraging a grant in partnership with the board to provide even more training in Cuyahoga County. And so I think it's interesting how innovative people can be even in these remote, hard-hit economic areas to do more with less. The other area I think is sort of frustrating, had been frustrating, was that we weren't reaching the young people in the colleges and universities and those that don't go to college. And they were having the experience of mental illness and felt so very alone. And many times, with the onset of their mental illness, because they couldn't have a conversation about it, because there was so much stigma, they chose to end their life rather than, those kinds of decisions shouldn't be on the table. We should be offering options and choices and normalizing the experience of healthcare so that mental health care is part of the healthcare be healthy kind of outlook rather than seeing it as those folks who are the most severe.
Rita, Better Health Greater Cleveland is focused on improving the health of people living with chronic disease. We know that behavioral factors have a large causal factors of chronic disease. Can you talk a little bit more about the strategies that you found more effective at engaging consumers and helping them become more active participants in their health?
So, a lot of our work in the past several years has been emphasized with improving clinical care with providers and bringing employers and payers into that. But we really realized most recently that, again, engaging the consumers is equally important. We have that alignment with all the right incentives in place. So some of that value-based insurance design that Margaret mentioned, we are trying to work with employers and health plans on looking at that more carefully to say, how can we remove barriers for those consumers so they get the access to the care and the medications that they need. But on the flip side of that, to build in some incentives for those individuals to adhere to their care plans and to make sure they take advantage of that. So to put those right incentives in place is very important. At the clinical level, we are working with providers in some new communication kinds of techniques, so using patient portals through the EHR we found to be very effective. Certainly my part with the Epic system with Cleveland Clinic is great. We have now held information exchange between the clinic, mental health, and Kaiser, and consumers are aware of that and understanding the power of that and giving that permission that those records can be accessed. There are some pilot projects going on now called Open Notes. Again, another Robert Wood Johnson-driven initiative that would give all of us as patients access to our medical record, the full record, so that we can understand better what's going on with us. Maybe you're a caregiver, a daughter or son of a parent, and you can't go to every appointment, but they can give you permission to look at those notes and know what's going on. We're training providers on techniques called motivational interviewing for behavior change, so we can get people to change their lifestyles, because that's a big component to the health outcome that we want to see. We have chronic disease self-management programs using the Stanford model, and we will work with groups of patients at a time who have chronic disease go through this program, which is several weeks in length. The one that we have going at Metro Health, we've been studying for a little while, and I'm happy to say that 31% of those participants in the program have demonstrated improvements in glucose control by as much as I don't remember the exact numbers, but improvement. And 39% improved their BMI, 36% blood pressure and 23% their LDL. So we're seeing some early results with this kind of chronic disease self-management programs. These can be offered out of any healthcare organization for their patients. Employers can offer it to their employees, and it seems to be a working model. And finally, we are just rolling out a campaign called Choosing Wisely. We got a grant from the American Board of Internal Medicine to help educate providers and consumers about the recommendations that came from medical specialties about a year or so ago that Consumer Reports has picked up. That is all about having better conversations between providers and patients about what kind of medical tests and procedures are really necessary for my condition, which ones might cause me more harm than good, and to just start to facilitate those conversations so that consumers can make better choices. And we have a lot of good videos on our website about that as well as the Consumer Reports. We have a lot more work to do in this space, though.
Thank you. And Michael, system transformation is having a significant impact on the way you deliver care. Can you talk a little about how you're changing the way your staff thinks and works to totally change the way that they deliver care to consumers?
So I think Director Moody mentioned this. These aren't times for the faint of heart. So there is a lot of change and a lot of uncertainty. So preparing for that, probably has 2 or 3 dimensions that are worth mentioning. I think the first is to make sure that caregivers understand and are educated about